And here's my disclosure. And this is all I've thought we discussed for today. I will start with the Parkinson disease and effect of deep brain stimulations, and then you go to the basic DBS programmings and to the advanced programmings, and then I would like to introduce you to the brain sense technology for the deep brain stimulations. So we're going to talk first for the Parkinson disease and effect of deep brain stimulations. I would like to show you for natural history for Parkinson disease. Most of the Parkinson disease people, at the beginning of the diagnosis, usually the neurologists will diagnose patients according to the diagnostic criteria. Mostly we use the United Kingdom Parkinson disease brain bank criteria. Once the Parkinson disease patients were diagnosed, the symptoms, including the motor and non-motor symptoms, can be seen. And also the treatment with oral state medications should be persist at the beginning of the symptom. But by the way, once patients start for the motor complication, usually start around 3 to 5 years after the treatment starting. And we found that some of patients might have the motor complications, including for the wearing off symptoms and also with dyskinesia. So that's why the advanced stage of the treatment might be considered, including the oral medications, non-oral medication, infusion treatment, also for the surgical treatment, including the deep brain stimulations and ablative surgery. And this is the deep brain stimulation system. I will not touch here because Professor Chuan's already discussed about this. But all of the DBS system will implants underneath the patient's skin. And this is the timeline of DBS procedure. Usually for the preoperatively at the first 6 months before the surgery, this is a key role for the neurologists. We usually identify the patient's evaluation, we check for the LED challenge, and we check for the patients that optimal the patients for the surgical procedures or not. And this is a hospital admission in our center around 7 days. And then patient will be discharged, and then we wait for 1 month before we turn on the stimulation setting that we call the initial programming. We usually wait around 1 month or 4 weeks because most of patients after they are doing DBS, they have the implants of the brain, and the first time that they implant, most of them have to have the improvement of the symptoms. At the first time, even they didn't turn on the system, that we call the micro lesioning benefit. And that's why this benefit usually persists for 4 weeks, up to 4 weeks. So we usually turn on the DBS after the lesioning benefit is gone away. And this is works of the neurologists that we have the need to do the initial programmings, and we need to do the follow-up sessions of the programming. And this time we usually adjust the setting by increase the setting ups and lower the medications down together and observe for the patient's symptom throughout the course of disease. And we go to the basic DBS programming. DBS programming usually have the 2 conduct sets for the programming. The first thing is we do the initial programming sessions after around 1 month after patients have do the surgery. And then we will go to the stabilization period that we usually stimulation starting by increasing the stimulation setting ups and lower the medications down together. But for the initial programming session, we usually postpone, as a reason I mentioned to you, for the 4 weeks because we are aware that the microlesion benefit might be interfere the effect of the stimulation. So we usually wait for 1 month. And then for the first time that the neurologist need to be turn on the system, we will discover the neurosurgeon first. How about the lead time that he used? How about the intraoperative periods? And how about the result at the operations? And then we will schedule for the patients at the early mornings because we usually withhold the medication for patients at least 12 hours to make sure the patient is off state before we do the first programming to the patients. And also at the time that we see the patient, we check all the surgical implants, if there are any infections, if there are any problems or not. And also we check for the impedance of the system to make sure that all the system is in the good functions. And also we focus on the initial programming based on the patient's symptom in the 4 category. And this is the lead check that we need to do. I show you for the lead types of the Medtronic, that is like a 4 quadripolar that have the one side of the brain and one side of the brain. So for the left brain, have the 4 contact, 0, 1, 2, 3, and control for the right body. And for the left brain, they have the right brain contact, 8, 9, 10, and 11 control for the left body. And this is the location that we did for the ASEAN and for the GPI. You need to check the locations again to make sure that right now the lead is a properly suitable locations or not. And therefore, neurologist will be turned on for the DBS system. And this is very easy, very simple information that we need to identify for the patients, because for the first time that you would like to turn on the system, The first thing is you need to have a look for the polarity assignment, because the system will have the flow of the electrons, and electron usually flow from the negative to the positive. So this is the thing that you need to do for the electrode assignment. And then we will do for the electrode configurations, because we need to identify that how we deliver the stimulations to the patient. We deliver by the monopolar contacts, or we deliver by the bipolar contact. This is the basic programming, because the monopolar contact, we have the cathode or the negative in one contacts in the brain, and we imagine that for the IPG or the battery become as an anode or the positive. But for the bipolar, we have the either one contact as cathode or the negative, and one contact as an anode or the positive. So the comparisons of the field that occur, we can see that for the monopolar, patients have more of the wider area for the stimulations, and also can get more benefit from the stimulation, and at the same time might have more side effect. So that's why one patient have the side effect from the monopolar contact. You can consider for the bipolar contact, because this provide more narrow of the stimulations and more precise stimulation that can be get patients more better in movement but less in side effect at the same time, but usually get more consume of the energy of the system. And the good thing is of deep brain stimulation is for the adjustability, and there are 3 parameters that can be identified for determine for the size and intensity of the electrical fields. The first parameter is the amplitude. This is the main parameter that control for the intensity and the size of the stimulations. And once you increase the amplitude in either voltage or in either the current or the milliampere, it will be increased in the area of the stimulations. And pulse width is the second parameter that can be contribute to the size and intensity of the stimulation as well. And once you increase the pulse width, you increase more additional activating neurons. And the third parameter that can be influenced to the size and intensity of the fields is the rate. But by the way, the rate I didn't use a lot, because mostly the rate have the influence as the third parameter. But we usually touch the rate if patient have some problem. For example, if patient have a shaking a lot, sometimes we increase the high rate, because a high rate of the setting might be helpful for reduction of the tremor. But at the same time, if patients might have the problem with speech abnormalities, might have the problem with the gait and balance issue, sometimes we can use the low frequency stimulation that might be helpful for the patient as well. And this is a samples of initial programming sheet that we have in our center. And this is usually we start with initial programming with the basic setting. We use the pulse width at 60 microseconds and the frequency of 130. And we identify for the ASEAN and identify for the GPI according to the decision at the time of the surgery. And we designate for the left side of the brain or the right side of the brain at the beginning. And then we will increase the setting to the patients and see for the benefit and the side effect, and to make sure that we get the good contact to open or not. And when you assess the setting for the patients, usually we start set as a monopolar. For example, we start with the negative at the zeros as a cathodes, and then we imagine for the set of the IPGs or the battery at the positive or the anodes, and then we slowly titrations of the amplitude until patients have seen the good benefit of the symptoms, reduction of the shakings or the tremors, and also is there any problem with the side effect occurs, in which level that we increase the settings or not. We usually slowly titrations of the amplitude in either voltage or the currents in the terms of the microampere according to the system. But by the way, you need to ensure that which level that patients get the good symptoms and have the side effect. Once you get this kind of information, you can select for which contact is the best contact, second best contact, third base contact, and the poor contacts. And usually when we turn on the first time, we will usually use to setting the configurations to be the monopolar. And we use the base contact as a cathode, and we use the IPG as an anode. But by the way, if patients have the problem further after we turn on the system, and we found that this problem according to the area of the synapse is too large, so that's why we would like to narrow the system. We can select for the bipolar contact, but for bipolar, I usually switch in either use for the base contact and match together with the second base contact together. So this is very easy one. And once you have the patient's symptom at the first time, you need to have the score to monitor for the patient. We usually use the UPDS motor section score to monitor for the patient's symptoms, and we ask patients walking. We have doing the video tape to the patients and document for the medications and also with the setting parameter that we provide to the patients and the outcomes. And also this is for the beneficial of patients after we increase the setting, because there are mostly 3 symptoms that we can identify to the patient. Is that correct? First one is the rigidity, for the tremor, for the bradykinesia. So I would like to ask for the audience, once you increase the setting, which symptom that you think that it would be the first symptom that improves after you increase the setting? Rigidities, tremors, bradykinesia. Which symptom do you think that's supposed to be faster, the first symptom that improves? The answer is the rigidities. Rigidity is very fastest one that you can observe right away after you hit the settings. And then tremors is later symptoms, but bradykinesia, sometimes you can follow up with bradykinesia up to few hours or few days. So that's why mostly we didn't observe for the bradykinesia at the time that we turn on the stimulation or increasing the stimulation, but we check for the rigidity and the tremor first. And also for the signs effect, we usually check for the motor contraction. We usually check for any of the signs of the contractile eye deviations or facial pulling or something like that, because these kinds of symptoms usually occur right away after we increase the setting into the narrow of the area that have potential to cause a problem. So by the way, dyskinesia is kinds of symptom that can be occur after patients go back to home. So that's why even at this time, patients have no dyskinesia, don't worry, because you need to document patients that you might have the dyskinesia after you go back home, might be few days, couple of weeks. So if you have that problem, no worry, because most of the patients with ASEAN target, this is a target that usually aggravate dyskinesia. So that's why most of ASEAN target patients usually can be able to lower medications up to 50% at the first 6 months. So by the way, but it's quite contrast to the GPI target. That GPI target, this is anti-dyskinetic target. So most of the GPI patients cannot reduce the medications, but get the good symptom. Even they need to increase more medications to the GPI target, but patients have no dyskinesia. And this is examples of the stimulation-related side effect that we usually find the patients, but we mostly target for the muscle contraction, for the paresthesia, for the diplopia, for the contractile eye deviation, because these kinds of things we cannot allow patients to use. But by the way, if patients have the dyskinesia, that can be okay, because if you have dyskinesia, you just mention to the patient, you can be lower your medication and overall things might be improved. Okay. And this is the samples of the stimulation-induced side effect of the ASEAN. The first video, patients have the inability to turn his gaze into the right side, so he have the contractile eye deviations. And also for the second video, patients have the facial pullings on the right facial after we increasing the surfing of the left facial. It means the patients have the spreadings of the surfing into the muscle fibers and into the cortical text area, and also with the frontal eye field area. So that's why this usually might be as a result of the monopolar stimulations, because monopolar usually provide more wider and more power or the energy than the bipolar. So that's why when you have the patients who have the signs effect from the increasing the surfings, and you think that the size of the stimulations might be can be explained for this kinds of problem, you can think about how to adjust something. For example, you can think about using the bipolar stimulations for the patients. You can use the guide cathode. This is anode, cathode, and anode. This is more like a more narrow shape for the stimulations. You can use the interleaving stimulations, and you can also ask patients to use the group programming. And also, at the same time, they can select the best group or the best setting that can be used in the future. And this is samples of the initial programming sheets that I complete. And at the same time, for the patients, I try to monitor for the improvement of rigidities, for the tremor, and sometimes with the bradykinesia. And I find out is there any problems occur for the facial contractions or not. And then once I complete all the charts, I will select for the first base contact, the second base contact, and the third base contact, and the fourth contact together. And the first time I open with the cathode on the 2 contacts, and then make the IPG as the anode. But if this patient, once I increase the setting for this patient and they have a problem, I might consider to use the second and third contact together to make a bipolar to narrow the therapeutic window to the patients. And this is a pattern of the typical stimulation parameter to the patients that we can use when we adjust the DBS system. We can identify for the ASEAN, identify for the GPI and VM target. But by the way, most of the configuration that we use at the beginning usually might be the monopolar or the bipolar contacts. And to the final time, before you are already checked on the system, you need to check that patient is good on the system with the good parameters or not. And you check for the medication and also let patients know that he or she might have a problem with dyskinesia if they adjust for the ASEAN target. So once they go back home, no worry. If the dyskinesia occur, you just allow patients to notice that how they can lower the medication according to your prescriptions. And also, I will start with the patients for tracking the symptom, and if they have the dyskinesia, no worry. And also, patients need to read for the patient's manual truly to make sure that they understand how to use the DBS system. And as I mentioned to you, for the ASEAN target, usually once patient turn on for the ASEAN, this is dyskinetic target. So usually additive symptom together with the medication of the patient, and most of the dyskinesia usually occur intraoperatively. Once most of the case for the ASEAN target, once the surgeon, they put the lead into the patient's brain, sometimes the taumatologist still observe for the MBR, we can see that patients have a dyskinesia. So that's why it means that you are in the good place of the ASEAN. But by the way, patients might have the dyskinesia, but no worry, we can lower the medication in the future. But for the GPI target, this target usually get the good result for reduction of the dyskinesia. So most of the patients cannot reduce the medication because they have no dyskinesia. And sometimes you increase the medication to continuously improve the patient's symptom also. And for the management of the medication for the patients, usually 50% of the medication can be lower in 1 year after ASEAN DBS surgery, but medication for GPI usually remain unchanged. But patient will have a good result for reductions of the dyskinesia. So that's why most of the patients I select before I send patients to the neurosurgeon, if patient have some of minor dyskinesia and use of the medications very high level, for example, the levodopa equivalent dosage more than 1,000 milligrams, I prefer to do the ASEAN. But if patients have a significant dyskinesia, very troublesome dyskinesia, even they use a very low dose of the medication, this kind of patient I will select for the GPI target. And for the follow-up programming visit, we check all of the symptoms of the patients together with the symptom, medication, the patient's change, is there any reduction of the medication occurs or not. And I also check for the adverse event that occur, and I will plan for how we can adjust for the next time to the patients. And also, I will check for the functional capability of the patient. For example, how patients can do. For example, household, core, leisure activity is still in the good functions or not. How to do the self-care hygiene. Is this okay for the patients or not? And this is one of my patients that he have the good result from the ASEAN DBS. And this is the one question that most of the doctor ask me after patients undergo the deep brain stimulations. Do the patient can be able to swim or not? So this is a recommendation. The patient can do the exercise also with the swimming. But by the way, try to ask your patients, do not do the exercise. That might be the contact or the pressure to over of the implantations area. And so after patients, usually at the first time of we initial programming patients, we usually ask the patients to come to see me in the outpatient clinic, mostly around 1 to 2 months regularly, up to 6 months. And then if the patient have the good stable of the medications together with the stimulation setting, we will allow patients to see for a bit longer follow-up, for example, 4 months, 6 months later that. And then we need to recheck again that is there any problems occur, and also for the battery paradigms, is there any alert for the battery that might be have the you need to replace new batteries or not, or any problem with the contact or the systems or not. And for the advanced based programming, due to the most of the patients usually get the good result with the basic programming. But by the way, we will consider for the advanced programming if patient cannot fully achieve the good result even they use the basic programming. So that's why the advanced programming might be helpful to lower of the patient's side effect and might be improve the patient's symptoms. And right now we can identify 3 of the advanced programming for the Medtronic system that we can be able to use this strategy to manage by lower the side effect. For example, we can use the lower frequency stimulations, we can use the interleaving stimulation, and we also ask the patients to use the group programming to select by themselves which group that they be love to. So that's why you can target this group at the next time. There are some studies of the low frequency stimulations that might be very helpful to lower the problems about the axial symptom, the speech problems, problems in Parkinson's disease who underwent the bilateral ASEAN DBS. And low frequency stimulation we usually use around 60 to 80 Hertz. But by the way, compared to the high frequency stimulations, we use mostly 130 and more. And we found that one patient using the high frequency stimulation for a long period, some of patients might have the problem with balance and speech problem. So that's why if your patients have the problem like this, low frequency stimulation might be considered also. So we show you one of my patients. She is the 65 years old woman who have the Parkinson's disease for many years. And this is the time that before the DBS surgery, and this is the onmet period. She have quite pretty good during the onmet, but she said that the durations of the on this is very short, and she have some minimum of dyskinesia. By the way, due to her symptoms is fluctuation, so we allow patients to do the deep brain stimulations. And this is the problems of the patients after 6 months post-operatively. Due to the patients, she said that after surgery, she get a good symptom, especially for her mobility in upper extremity. But after 6 months, she noticed that she have more of the gait abnormality. She have the freezing of gait, especially when this patient is using the high frequency stimulations of 130, and she perceived that even though the upper body seemed to be better than before the post-operations, but her freezing become more problem at this time. So these patients, what do you do? Do you think this is problems of the stimulation induced side effect, or this is the disease progression of the patient that might have the more of the disease progression, have the more freezing or the poor balance, or what else? What do you think? Please. Yes. Okay, so this patient, at the beginning, we think in ITER. So first thing is, this might be as a result of the stimulations induced gait freezing of the patient also. And also it might be the alternative, that might be as a result of the disease progression. So that's why the first thing that I did for the patients, I lower the setting to the patients. And I try to lower for the dominant hemisphere by 0.5 volt at that time. And I found the patient report that he had the improve of the freezing when compared to use the same setting. This is the recommendations. If you have the patient who have the freezing or the gait problems after using the ASEAN DBS, the first thing, if you think that this might cause as a stimulation-induced effect, sometimes you cannot turn off because this is gait function. You cannot turn off because if patient become off, he cannot walk at all. So that's why we recommend you to lower the setting. And I recommend you to lower for the dominant hemisphere, for the left ASEAN first, just 0.5 and see right away that patient improved gait or not. And this patient, she report that she have improved and less of freezing when compared to use the usual setting. So this patient, we tried the lower frequency stimulations later with the 80 Hertz. And we found that she have the less of the freezing, and she reported improved of her mobility and also with less poor balance. I have show you about the gait parameters of the patients when compared between monopolarized contact 130 and also with the same contact but 80 Hertz, and we found the gait parameters just significantly improved after we lowered the setting into the low frequency stimulations to the patients. And also we identified that low frequency stimulations still can be helpful for patients with speech and stuttering also.
อยู่แล้วข้อดีของอาหารเลยอ่ะ
This patient have the problem with the speech,
ประ
have
โย
the
ชน์และ
slurred
ข้อ
speech.
ดีของอาหารเลยกัน
Also with these patients,
ป่วยเป็นโรคพาร์กินสันแต่อายุ33 ปี33
he have the significant stuttering
ติดนะครับ
after we using the monopolar system. And also this patient, he have also with the problem with balance, with freezing at the same time. So he fall and he have the broke of his teeth, also the same patients. So that's why this kind of two patients, we adjust into the low frequency stimulation and find that all the symptoms is improved. And this is, yes, low frequency stimulations, low frequency. But we try to keep the TEED as the previous to make sure that patients have the capability to mobility as usual, but we lower just only for the low frequency only. Yes. And this is our study that we published a few couple of years ago, and we found that patients who have the ASEAN DBS have the intensity to have the problem with the speech abnormality and also with the poor balance. And we found that when we compare between the low frequency stimulations and high frequency stimulations, patients who have the low frequency stimulation have tendency to have louder of the speech compared to patients who use the high frequency stimulations. And also, if I designate the little orientations into the below, this is more ventral and ventral, dorsal, and most dorsal. If patients use the active contact in the dorsal contact, most of patients might have the problem with the speech abnormality when compared to patients using the ventral contact as active contacts. And I will go to the interleaving simulations or the multiple programming at the same time in the one lead. This is a patient who have the Parkinson disease more than 30 years. And I've seen this patient more than 10 years. At the first time, he had the significant problem with the off periods and his symptom really fluctuation. Once he's taking the medication, he have dancing a lot. This patient at the first time, we think about to use for the infusion therapy. But this patient, he have the problem with the nodules. So that's why he cannot undergo for the infusion therapy for a long period. So we consider this patient for the deep brain stimulations as well. But after 1 year after surgery, this patient complained about the speech problem as well. And his wife commented that his speech become soft and very difficult to hear. So that's why I just checked the system of patient at that time and please see and please listen about his voice. So his speech is very soft. And I checked the contact. This is the monopolar contact with the high frequency stimulations of 130. So that's why, what will you do? I just do for the speech, I will turn off. Once you turn off, you can hear. Obviously, improve of his speech, more a bit louder after you turn off the system. It means the patient is supposed to have the stimulations induced speech abnormality. So that's why this patient, I think about it either for the bipolar contacts and I check for his speech again. And another type is for the interleaving stimulations. Seem to be better. So that's kind of these patients, once patients have the problems, we just decided to using the good surfing that provide the good mobility to the patient and also less side effect to the patient at the same time. And also, this is a simulation-induced side effect that can be found in patients with dyskinesia. And this is the areas of the stimulation that can be identified if we would like to lower the dyskinesia to the patient in the subthalamic area. This area in the zona incerta can be used to stimulations in also to lower the side effect of dyskinesia. And this patient have a dyskinesia of her left side. And also, once she walk, her left arm, this is become swing. And also, once I use interleaving stimulations and I try to stimulate at the dorsal fiber of the subthalamic fiber, patient have the improve of her dyskinesia and she have less of her left arm swing as usual. And this is a group programming.
We run out of time.
Okay, almost done because you have 3 slides left. Thank you. This is a good programming that you can be offered to your patient for selected. This is telehealth that you can be identified for support the patient's follow-up. And also, this is our report of patients who have the problem with the hypoparaxia syndrome at the time of the battery dysfunction at the time of COVID. And we think that if patients who underwent deep brain stimulation, they're supposed to have the emergency contact, even with the telemedicine, to follow up with the doctor in the center. And this is our teleconsultations clinic that we allow patients to show the system and also with the functions of the system that it be good for working or not. And this is the brain sense. But by the way, that's the time we have the commercial of the method that we can identify for the local field potential that can be identify the location that be good to simulations for the patients or not. And we found that the beta band, this is correspond to the akinesia pattern. So that's why if we can lower the beta band, we can improve the patient's mobility. So this is one of the systems that can be available as a commercial right now. The name is BrainSense. Thank you so much for your attention. And this is my last slide that I talk about deep brain stimulations. DBS, this is a diagnostic skill and have the better DBS can often require and also can reduce for the motor fluctuations to the patient. But by the way, good programming of DBS with the optimal stimulation is a key success for the deep brain stimulation surgery. Thank you for your attention. ขอบคุณค่ะ